Hello, my name is Savannah Seay. This is my level 1B fieldwork reflection video. I was placed at TriStar Summit Hermitage. My CI was Reggie Grimes Sr. So getting right into it. For number 1, task analysis and critical thinking, we had a patient recovering from a stroke with poor sitting balance. She leaned to the left and had left side deficits. To combat this, we analyzed the task of sitting edge of bed. We decided to have the patient reach across her midline to grab a pack of wipes that I was holding across her body with her left hand. We also had her hand it back to me to engage her core muscles required for sitting edge of bed. We tried independently sitting on the edge of bed again, which was not working. She was leaning to her left again. And she also had a fear of falling. So then we gave her tactile sensory input on her left shoulder to decrease her fear of falling while she rested her left hand on her left knee to provide stability. After those things were done, she successfully sat on the edge of bed with us standing by, so with standby assistance, for 7 minutes. So that was number 1. Number 2 would have been adapting tools and materials. So we had a patient present with stroke-like symptoms secondary to a UTI. She had contractures and little control when performing intentional movements such as eating. We used a built-up spoon and fork during breakfast to see if it would help promote her grip strength and controlled movement, which it did. So that was awesome. We also graded down a clothespin activity by putting them closer to the edge of the cup. She used yellow, green, and blue, and red clothespins, and we had them around the edge of a cup. And when we realized that she was just kind of like pulling them off rather than pinching and squeezing and pulling up to get them off, we moved them closer to the edge of the cup. She was able to get all of them off successfully. Number 3 was for environmental modifications. This one was really cool. A patient with partial foot amputations because of diabetes was on non-weight-bearing precautions and needed to use the restroom independently. So we were using a regular bedside toilet, but transferring from bed to toilet required mod to max assist due to the weight-bearing precautions. We suggested a sliding board to make that transfer easier and possibly help him increase his independence when transferring, but he denied it because he said he didn't have one at home and he wasn't going to buy one. So then we had to think outside the box. We then got a bedside toilet with a drop arm to increase that safety during the transfer, and it had a platform for him to be able to push up using his arms, and he was able to successfully transfer himself from bed to toilet with us just standing by. And sometimes he did require us to hold his feet up off of the ground to remind him, hey, you can't put weight on them. But using that toilet with a drop arm was an environmental modification that we implemented, and it did work. Number 4 was psychosocial engagement and ability or disability. We had a patient in the surgical ICU that experienced frustration, stress, low self-esteem, and he was very overwhelmed due to losing independence after his admission. He was very tearful during the session, which is kind of where I got those psychosocial factors. And he also explained to us that he felt like he wasn't a man anymore because he hadn't been able to use the bathroom on his own or get dressed or go walk since he got admitted into the hospital. And due to his tearfulness, that increased distractibility because he just really wanted to vent and explain to us how dehumanizing it felt. We addressed these factors by being empathetic and offering tasks to regain sense of independence. We did quite a few transfers by taking him to the in-room toilet in the ICU. So we did supine to sit, sit to stand, bed to in-room toilet, toilet to bed, and then he stood for 2 minutes. Then he sat on the edge of bed and then laid back down. During this time, we had his family come in to see the progress that he had made and see him finally out of bed, and that gave him an amazing sense of joy. He was overjoyed and overwhelmed by the fact that he was able to go use the restroom on a real toilet rather than in the PureWick or using his catheter. He was beyond joyful, thankful, and he told us that he finally felt human again. And the patient and his family asked if we could be the ones to come back the next day for treatment. So that was really, really awesome, being able to see how psychosocial factors can impact someone's ability to participate. Number 5 is impact of psychosocial engagement on performance. Again, this is the patient with the stroke-like symptoms due to a UTI. She had decreased self-efficacy and embarrassment regarding her ability to self-feed. I kind of got this because she was talking about her experience and how long her symptoms had been going on. And she was explaining like how terrible it was to not be able to feed herself and how she had a really hard time pressing the call button to ask the nurses for a sip of water or to help her eat a snack. So I sensed kind of some embarrassment, and in the words that she was using, she was saying, I can't. So that led me to see her decreased self-efficacy. These factors stopped her from trying to feed herself and give herself water entirely because she was just so accustomed to not being able to, and the embarrassment and the decreased self-efficacy. She genuinely thought she couldn't do it anymore. So her sister also believed she was not capable of feeding herself or giving herself water. So having someone else telling you that kind of reinforces those negative self-talk and those psychosocial factors. And because her caregivers around her thought that she was not able to at all, she just never tried to feed herself independently. To combat these factors, we used ample words of encouragement, celebrated successes. Whenever she was able to put that first bite of food in her mouth, we went overboard. We went above and beyond in encouraging her and celebrating her because that was a major, major win for her. And we pushed her to try it for herself outside of therapy. So during breakfast time, the patient care techs, they would go in and they would help her feed herself breakfast. And so we encouraged her to try at least a couple bites every morning or every mealtime, and to try and give herself some water, because at the end of the day, water dries, and if she spills it, that's okay. And she said that she would try it with waters that she had already drank out of, so they weren't as heavy. So I really do think that those words of encouragement, celebration of successes, and the push to try outside of therapy really did work for her. And the last question is integration of knowledge across objectives. So with that same patient, we used task analysis to assess the task of self-feeding. And we gathered from watching her and seeing her the previous day that it was her grip strength and ataxia that caused her to not be able to feed herself. So we looked at the task, and we thought about how we could adapt or modify the need for grip strength or control of her upper extremities to fit her current level of function. And through that, we created an environmental adaptation using the built-up spoon, but we also changed her positioning, the table height, increased the lighting, and muted the TV so we could focus, so we could feel close enough, just give her more sense of security and safety, and create an environment that she was able to focus in. And using psychosocial engagement, we educated her sister on the use of adaptive equipment and emphasized the importance of it, because she had mentioned she had some of these adaptive tools at the previous place that she lived. It was an assisted living facility, I believe, and she did not have them with her. So we were educating her and the sister on the importance of making sure that she has those things, especially whenever she's being hospitalized and her symptoms could get worse. So that was a big thing, and we educated her on self-advocacy and reassured her that we are here to help her, so she should never feel embarrassed or like a burden to hit that call button and ask for help when she needs it. And it seemed like it really did work. From this experience, I learned how to identify the area of growth that we could focus on during intervention and understand where adaptations can be made and what type of adaptations can be made. And I also learned about the importance of educating not only the patient but family members on use of adaptive equipment and the importance of it, because a lot of times people don't truly understand the importance of it until they see it or until they understand the logistics behind it. So that will absolutely influence my future practice, because I will put an emphasis on patient education, family education, and most of all, just words of encouragement and celebrating those successes and pushing the patient and the family members to keep practicing these things outside of therapy, because those are super important. Overall, this experience has been so educational for me, and I really didn't expect to learn as much as I did being there. So it was an amazing experience, and it was just, there are so many areas of focus that I hadn't thought about before. So it was a very educational experience, and I really enjoyed it. Thank you.